just the slide showing that we've discussed the reasons for doing in vivo microscopy. The technology OCT that allows you to see architecture morphology and all of the capsules that we built with that. When you want to see cells, you can move to confocal microscopy and technologies like SECM and OBM. And then micro OCT, which provides histology quality resolution without requiring any labels. And dynamic micro OCT provides that added dimension of metabolic activity that you can't get with microstructural imaging alone. So we think that as these technologies mature, we indeed will transform pathology from today's pathologist who sits in their office looking at slides to tomorrow's pathologist who's actually looking at microscopic images in the living patient and deciding what to do in real time. To change how we do diagnosis, instead of like stethoscopes and blood pressure cuffs, we're going to be able to screen for cancer by swallowing capsules. And then ultimately, we're going to have these micro robots moving around the body, autonomously making decisions about what to do and treating the first cancer cell or the earliest stage of disease instead of waiting until it's too late and there's nothing that can be done. So with that, thank you very much for listening to my talk. This is my lab, and this is my contact information if you want to follow up on any of the things you heard today. Thanks. I guess we have time for a few questions. Yeah.
Sure. Please feel free to come to the microphone.
That was a great talk. Thank you guys so much. With the micro OCT, have you done any segmentation looking at like cellular volume compared to nuclear volume to get like some type of dysplasia or
index? Yeah. No, it's really new. So it's a early field, and like those kinds of things do need to be done. And also, things have really changed with machine learning and the kinds of patterns that we can pick up, and so that's a big part of what we're doing with all of these technologies.
Awesome. Thank you.
Thanks.
One question for me is keratinized versus non-keratinized skin, like the mucosal surfaces, you get really amazing imaging. When they're more keratinized, like the skin, like what we deal with, how do they? It
works pretty well. It works pretty well. You saw the images, I think, of the skin that we have. So yeah, it works pretty well. I mean, this also, there's a lot of work to be done to make the technology better. And one of the problems that we really have with this is stabilization, because you need to keep the image stable for like a second in order to get the image. Because you need to grab multiple images over time and reconstruct the frequency of motion that exists in the cells. So the hardest part with doing it in the skin is keeping the skin stable. And so that's where all of the research is going right now, is stabilization methods or ways to register the images after they've already been acquired.
Awesome. Thank you. And you'll be around for more questions?
Yeah.
Okay, sure. Wonderful. Thank you again.
This is a weird dynamic with the entire group over there. And no one sitting in this part. That's crazy.
You can't see the screen.
All right.
No, that was an amazing lecture. One quick question: what's the most commercially available now, Dr. Tierney, out of all those?
The OCT.
Okay. The GI OCT, yeah.
GI, coronary, retinal.
Nice. So we'll switch gears slightly. I'll be talking about confocal microscopy, reflectance confocal microscopy for the diagnosis and management of skin, specifically skin cancers. I'm a clinician, dermatologist, derm surgeon, so I really work with our optical engineering group at Memorial Sloan Kettering under Milan Rajashaska, who also trained at MGH, and he's really leading the way in the engineering portion. So really quick, just to give you a brief overview, in all of our specialties, and the beauty of ASLMS is we're bringing multi-specialty groups together, we have many imaging modalities. And so we're really familiar with imaging, radiographic imaging, ultrasound imaging in other fields. In dermatology, we relied heavily on pathology, like Dr. Tierney was saying. Pathology seems to be the gold standard in both arenas. However, with the onset of new technology, optical coherence tomography, as well as reflectance confocal microscopy, we're really changing the paradigm of how we image the skin and detect skin cancers or manage them and treat them. So this is a brief outline. There needs to be improved detection. What are the current technologies that are really available in the clinic, right, outside of the lab? What's the future hold, and why are there challenges? And just to put it in perspective, skin cancer is the #1 most common cancer in the world, obviously. Its prevalence is quite high. And so the global burden of disease is there. And so detection, right, early detection is imperative. And especially when we see patients like this. These are patients who have dysplastic nevus syndrome. You know, they're covered in moles, and most of them are atypical. And as the clinician, it's mind-boggling. You know, you could sort of biopsy any of those. They all look atypical, but which one is the melanoma? So we need to get improved diagnostic tools for the identification of true skin cancers like melanoma. And the current technologies that people are using readily include, amazing digital imaging, digital photography in general, and then the use of total body photography, UV photography, as well as dermoscopy. Dermoscopy was a game-changing tool for clinicians in dermatology, just to use polarized light, right? Just to understand the subtle structures that are occurring in the skin that we can use as viable clues to detect malignancy. And then we layer on top of that reflectance confocal microscopy, optical coherence tomography, and then there's other ones, multispectral imaging, diffuse optics, multiphoton microscopy. These are more research-based. But just jumping into total body photography, at our center we use 3D total body imaging to really get a baseline view of the patient and what their skin holds. And this is the commercially available device. And you could see that just by taking this 3D view of the body, we can get really good high resolution images that, like Google Earth, right, that Dr. Tierney was saying, we can zoom in and look at size, shape, morphology. Even you get the gestalt of texture in these images, right? So it's pretty amazing what we can visualize now just with the digital imaging tools that are available. And then when you layer on that machine learning, right? True AI-driven automatic lesion detection and measurement, the machine can then sequence out what is truly a nevus versus what is just background pigmentation or your baseline skin tone, right? So through machine learning algorithms, this is not detecting the melanoma right now, but I'll show you how we do that as well. But this is just sequencing out what's actually a nevus and what's actually just your background skin. Even that is really important, right? Because as dermatologists, we would have to look at every one of those pinpoint areas. And then you can group these, right? And then now you can use machine learning as a diagnostic tool, and then take into account, diameter, color, size, morphology, and then we can layer on all those parameters with this algorithm to group these lesions and then classify which one technically, truly is the ugly duckling in this diagram. So this makes our job augmented, right? So it's not replacing the physician, which is what people sometimes are afraid of, but it's really augmenting the physician to perform at their best, especially in these most challenging cases, right? And that's the amazing part of all this technology. And so even advances in dermoscopy, including like mobile dermoscopy, teledermoscopy, has really transformed our reach as clinicians. And it's important, and especially in developing countries, that we can use this technology where it's not readily available. So there is this pyramid of therapeutic or diagnostic imaging, and it always starts with the clinical, right? So your clinical, you wouldn't just screen everyone with these advanced tools. You're really going to use your clinical acumen, layer upon that dermoscopy, and then layer upon that optical imaging. And it's really helped to bring down the number needed to biopsy, and it's improved our sensitivity and specificity overall. And just to let you see, the confocal microscope, it's similar to ultrasound, but instead of ultrasound waves, it's based on optical reflectivity. There's a light source, it illuminates a spot within the tissue, and then that light is reflected and detected. And you can scan, obviously in the X, Y, and Z plane, and we get these en face images. So the image is a little different than how we would see normal histology, which is more bread loaf. This is en face. So you're getting a really nice overall picture of the skin. And it's, it comes in these grayscales, but now with this sort of optical histology, we're dyeing these black and white and gray images to reflect more of what histology looks like. But the high refractivity structures look bright and white. These are melanin, keratin, collagen, and then melanophages and lymphocytes. And those with low or limited refractivity appear dark, so the nucleus and red blood cells. And we could image all the layers of the skin from the stratum corneum to the papillary dermis, but really the depth of imaging is the limiting factor. So anything more than about 200 microns, depending on how thick the skin is in that area. Jumped ahead, and we can also use this ex vivo, right? So we can use dyes to bind to the nuclear DNA to really enhance the contrast, and this is fluorescent confocal microscopy using acridine orange. It binds to the nuclear DNA, and you can really see this contrast nicely, and this is an image of a basal cell carcinoma. And then you can use fluorescent and reflective channels, and then combine them and use a digital staining tool to really mimic what we know already under pathology, so that H&E. So the digital confocal image looks very much like what we're used to. And clinically and commercially, these are available now. So they're available to use, and many of you may have used these already. This is the static arm-mounted one and the handheld version that we use often. And like Dr. Tierney was showing, there's so many applications that you could imagine for real-time imaging, especially of the skin, which obviously is our largest organ. Dermatologists love to say that. But there's so many useful things to do. We can identify biopsy sites, we can map out lesions, we can direct the management using surgical or non-surgical tools. So just to give you some real-world examples, this is a basal cell carcinoma, and we can image whole field, which you see in the photo B, and then in C you can really zoom in and look at the closer structures. So we can see the tiny nodule of a basal cell carcinoma. And this has really gone from bench to bedside. So things that were done in the research lab have really now crossed over to the bedside, and we're using them in real time in clinic every day. For me, the diagnosis of melanoma, basal cells, and squamous cells is really the bread and butter of this imaging, but it goes way beyond that. We can definitely diagnose BCCs in vivo, and all these features have been very much tested and worked out. Just to show you a little bit, these are elongated monomorphic nuclei, so this streaming pattern is very typical for basal cell carcinoma. Along with the nuclear polarization, the nuclei are polarized along the same axis, so they're streaming in this direction. And we can see this under histology, and we can also see it under confocal. The peripheral palisading that we actually see in pathology under the microscope, we see this in real time in intact in vivo tissue. So this peripheral palisading is this row of tumor cells around the nodule. The nuclei are arranged parallel to each other. And what's really interesting is, we always thought the clefting in basal cell carcinoma was an artifact from tissue processing and histology. But you can even see this sort of clefting and delineation in real time under confocal, if you can see. You can't see my arrow, but around the tumor you can see this dark space, and it's sort of like the tumor is retracting from the stroma. So that's a real occurrence that's happening in vivo, and it's not just a tissue processing artifact. These tumor islands are distinct aggregates of tightly packed cells, and they're pretty visible and readily noticeable under confocal. Even for the novice who's just starting, it's sometimes easy to recognize these patterns. So the learning curve is not as steep as other modalities may be. We can get into more nuances like chords and clefts, and these are cord-like structures that we see in certain types of basal cell subtypes, including superficial subtype and pattern. And again, these cleft-like spaces are really visible. And then blood trafficking, we can see real-time network of blood vessels and blood flow in vivo, and you can see this increased in many basal cells. Not only is it a feature on dermoscopy, but we now use it as a feature in confocal. And then also the tumor stroma. So tumor microenvironments are becoming really hot area of research for all different types of cancers. And we're using confocal now to explore the tumor microenvironment, not just the stroma, not just the dense collagen network like in basal cell carcinoma, but even things like melanoma. We can see cells that are being recruited early, and using real-time optics, you could see inflammatory infiltrates that are surrounding the tumor and comprising the tumor microenvironment. So that's becoming a real big area of research. So again, under dermoscopy, this is a very non-specific lesion. So, when you're layering your diagnostic tools, if you can't make a judgment call under one, you keep going. And so under dermoscopy, this is not very indicative of a basal cell carcinoma. So we can image it, and we see right from a global viewpoint, there's some keratinocyte disarray, there's some epidermal streaming, but then when we really hone in and go closer, we can see, boom, apparent, just these tumor islands that are reminiscent of the micronodular basal cell, which it was. And then you could see the clefting as well as the dilated blood vessels surrounding the tumor. And even, this is not a unknown occurrence. Sometimes people have multiple biopsies and they just don't even know where they were or what they had done, even though it's their body. So this patient was coming for surgery, but they had 2 biopsies side by side. One was called an angiofibroma, one was called a basal cell carcinoma. And this is you, because you're trying to figure out which was which is, sort of impossible right then and there with the naked eye. But using these non-invasive imaging tools, we can hone in on different areas, and here, we see some hair follicles, but not, and maybe some scar-like evidence of a biopsy. But here we see tumor island as well as like the stromal changes, and this was the basal cell carcinoma. So it's really fun to be able to really take a non-invasive view of the skin, right? You could just imagine this being projected to your, what used to be Google Glass, or now, the Apple Vision, right? You could just see this being projected to you in real time, and all of a sudden you sort of have what we always wanted, which was X-ray vision. But these aren't X-rays, right? It's just light. It's just light in a very distinct pattern and a focused manner, which is so cool. So, and patients love it in real time. So the fun thing about our job is that we can actually use this in real time with patients watching the screen. So they're visualizing it as you are visualizing it. There is a pitfall, obviously, to this technology, right? Which is the depth of imaging. So we can only image as far as the light will take us, and we can miss deeper seated tumors, right? So that's the caveat, and we have to be mindful of such. So to overcome that, our team is also developing these handheld RCM OCT prototypes, which combine, 2 technologies in, one channel, which is really cool. So we're getting both a, on-FOSS RCM view and a bread-loafed OCT view at the same time, which is, again, just layering these technologies together gives us better overall 360 views of the skin. And again, Dr. Tierney showed us some really nice photos of micro OCT. And as we push the technology farther, we're going to get better resolution and better scanning speeds as well. And we're doing it in harder diagnoses too. You know, to diagnose the minute AK, which is actinic keratosis, which is a precancer of the squamous cell in the skin, all the way to invasive squamous cell carcinoma, you know, it exists on a continuum. So now we're better characterizing this minutia and these details from, you know, one cellular atypia to full-blown invasive squamous cell carcinoma. We can grade these on a continuum. And then this is Milan. I have to, you know, show a photo of him because he's the inventor of many of these tools. So this is a oral probe, you know, for oral dysplasia and squamous cell carcinoma. So again, you know, the idea that these non-keratinized structures, we can see maybe even a little deeper because we're not blocked by the stratum corneum. And then switching gears briefly, you know, I like to discuss melanoma because it is one of our more aggressive types of skin cancers, and they can be quite subtle, and early detection is very helpful in this because early detection usually means a smaller treatment size. And there's been a lot of work by people like Pascal Gutierrez in Australia, as well as Giovanni Pellicani in Italy, and they've really characterized the features that we should see under RCM for melanoma. So things like non-edge papillae have been described, which are just basically descriptions of how the architecture is disarranged in these cancerous processes. The follicular localization of atypical cells, so these atypical melanocytes are really populating around the hair follicle and trailing down the hair follicle, as well as large round pagetoid cells. So these cells, these atypical melanocytes are now populating into the skin. And we see this under pathology, but we see it readily under confocal as well. Things like broadened honeycomb patterns, we can see in benign and malignant lesions, but just to give you a comparison to the normal shape of and architecture of the epidermis. And what's really cool is you can see these and show the continuum. So this is a melanoma that's arising out of a congenital nevus on the top. That's the clinical image. And confocal, you can see on the right, a very organized arrangement of nevus cells. They appear bright and very distinct, you know, and they're homogeneous. And then on the left, we can see these atypical cells. Some of them are dendritic, some of them are just bizarre shaped, and that represents the melanoma that's arising from that nevus. So really to just see this pattern in one image is really interesting. And this is an example from Gutierrez. This is, again, a dermoscopic image that has really no features of lentigo maligna. You could think this is just a bad sunspot. But with our tools, we can be detecting these early. Again, the caveat is like, are these biologically aggressive, right? Would these ever change into something that's even more aggressive? That's sort of the million-dollar question, but that's more research will have to be done on that. But the early detection is really key here. So we can see just from this global image the disruption of the epidermis, and you can see these bright cells that are populating the epidermis, and you would want to hone in on those, you know? And these are rather large in comparison to the other cells that you would see, such as inflammatory cells, so already they're larger. And then again, when you go higher power, you can see that they're much larger, they're irregularly shaped, and they're scattered. And now they're also localizing around these hair follicles, right? And they're destroying the natural architecture of the papillae. And for all these reasons, these are, you know, they were able to score this and say that this was a melanoma, which is what it was. And they've come up with a scoring system for lentigo maligna and the odds ratio of what each feature would actually predict to be a melanoma. So the broadened honeycomb has a slightly increased odds ratio, but these large nucleated cells within the dermal papillae have a much higher odds ratio. So if you see these, this is the scoring system, really 2 major features and 4 minor ones. And this is amazing work. They've imaged so many patients to come up with such an algorithmic scoring system for lentigo maligna, which is difficult to diagnose clinically. It's difficult to diagnose histologically, but it seems that confocal has a more readily accessible view of the skin without cutting. And then to further whet your appetite for these imaging tools, our team, our optical engineering team, came up with video mosaicing. So really stitching together these images that are captured in video format and stitching them together in a panoramic way to really give you sort of this elongated view of the skin. Similar to what Dr. Tierney showed with his OCT, seeing a long field view of the intestine, we can do this with the skin as well in a very fast amount of time. And for us, seeing this technology translates to how we do things clinically. So, we're still surgeons, and surgically we need to cut things out. And so imaging in this manner and capturing these videos and translating them into panoramic sort of blueprints of the skin, we're able to hone in on what margins we can take clinically and surgically to cut out skin cancer. And we utilize this technique for melanomas of the head and neck, mainly the face, where every millimeter of skin counts, right? Every millimeter of normal skin really helps us in the reconstruction of the anatomy. And so clinically, it's really hard to determine where these lesions start and stop. You can use things like Wood's lamp to enhance them, but getting imaging view using confocal, we can really readily see these dendritic cells that appear bright and white. And we can use this as a roadmap to where we would image, but then we would also cut onto that. So we image within the paper ring, and we image outside the paper ring, using the paper ring as sort of a boundary of our microscope. And then we can create this blueprint, right, in a circular fashion using these video mosaics, and then again hone in on areas of the most atypia. And where there's atypia, we just keep imaging outward to keep getting a margin of clean tissue where we can cut. I don't know if this works. Yeah, so then we can create sort of videos. That's the paper ring that you see there. So that's our boundary. We're crossing over it. And now we're outside the paper ring. We come back into focus. Again, hair follicle. You can still see some aspects of these dendritic cells, right? That's still considered a positive margin for us. We keep going. And we stop when we think that the margin is clear. And for many people, they're like, oh, well, why do you need that? You could just, take margins clinically. But for the patient, they want to save every millimeter of skin possible, right? Because it's their face that's getting cut. And we can use these in direct correlation with the histology from the specimen that we remove. And if you can see from this low power field, you can see the trailing edge of melanocytes within the epidermis, and eventually they just trail off. And that's how melanoma in situ of the skin really grows. There's a high density of these melanoma cells in the center of the lesion, and then they sort of just dissipate out and fade into the background. So we did this trial where we prospectively looked at this and imaged using standard margins that we would take, and then margins that we would actually take using confocal microscopy to guide us. And the margins in comparison were actually great. So we did 23 lesions like this, and the mean surgical defect estimated with confocal was 6.3 centimeters squared. And the mean surgical defect of the surgical excision with clear margins was about 7.7. So we actually sort of overestimated with surgery, and we were able to hone in even tighter with the confocal, right? Which is great, which is really helping us. And again, for much larger, this is a recurrent melanoma within a large facial flap where the patient had a previous melanoma. And we can really hone in on where is positive and where is negative, and then able to resect in all one swoop. And Brian Hitler and I published this paper using this real-time imaging in the OR, where the patient's asleep, and you want to get the margins right on the first time. So this is really helpful for our head and neck surgeons as well. And then even in really tough areas where we can get skin cancer, where people don't necessarily even want to biopsy, these non-invasive imaging tools are really helpful. So in the genital areas, and Dr. Tierney showed OCT of the cervical specimens, but even of the skin for really challenging extramammary Paget disease. And then we're utilizing it in novel ways in combination with new treatments that are non-surgical, such as immunotherapy, which has really changed the landscape of melanoma treatments or invasive melanoma treatments. So this was an invasive melanoma with in-transit metastasis on the scalp. It doesn't even look like melanoma, it's amelanotic. But the beauty of imaging is that even with amelanotic tumors, the tumor cells still appear bright and white. So it's not just the melanin that's reflecting. So tumor was unresectable, and they were started on a combination of ipilimumab and nivolumab. And you can see these are the tumors that we imaged before treatment. So you can see these necrotic, large tumor islands with these atypical bright cells, all representing the melanoma. And then after immunotherapy, not only do you see clinical resolution in the scalp, and you can even see hair growth, but under real-time imaging in the bottom right, you can see the tumor islands look different, right? They have different morphology. They're smaller. The cells are more shrunken. They almost look pycnotic, as you would see under histology, and they look necrosed. So the tumor has basically died. And we can do this with topical immunotherapy as well. So imiquimod is a toll-like receptor that upregulates interferon to give you more of a innate killing cell, innate immune profile. So we use this for lentigo maligna as well as other skin cancers. But you can see in the middle panel on the top, it's these bright dendritic cells that are representative of the atypical melanocytes, the melanoma cells in the lentigo maligna. And then afterwards, after imiquimod, not only do you have clinical resolution and the skin looks beautiful, but under confocal, there's the resolution of the honeycomb pattern of the epidermis, as well as the absence of any of these atypical lesions. And this is even post-radiotherapy, so radiation therapy, which is becoming more popular for early skin cancers. And I'm even doing this with laser ablation of skin cancers. So this is ex vivo pre-ablation and post-ablation, and then the histology that's corresponding. So using a CO2 laser to ablate early skin cancers without cutting. And this is, we published this as well. So another non-surgical method to destroy early skin cancers. And because, again, people who have multiple skin cancers are tired of getting cut or ED and seed, and these scarring patterns can be quite poor, right? So these are surgical scars, these are ED and C scars, but the green shows you a laser ablation guided by confocal microscopy scar, which is, we use lasers to treat scars. So the scarring is different from laser ablation. And then just using neat and nifty imaging tools, we could show the difference between a pre-laser ablation, immediately post-laser ablation, and then afterwards they're healed. So the right is the laser that's healed, the left is a traditional curettage, the ED&C. So, sorry. And so you can see that the atrophic scar is a bit more pronounced with the ED&C compared to the laser. And this was actually a fellow that I worked with, Simone Amato in Rome, Italy. He is using some cool imaging devices as well as confocal for scars, which I think is cool. This is a pretty wide nasal scar from dehiscence after skin cancer removal. And they're using multispectral and confocal analysis to assess the necrosis of the skin and really rendering these 3D imaging to better assess the depth of the scar as well as the components of the scar. Is it more vasculature that's contributing to the scar appearance, or is it more collagen fibrosis or more pigmentation? And then by using these tools, they can really look at the components of the scar and say, okay, what should we treat first? Should we treat, the vasculature? Should we treat the collagen? And then they can pick parameters. So they use the CO2 laser as well as a vascular pulse dye laser to treat these. And they got nice results. So they're using multiple treatments. You can see it goes through really different levels, but there was an aspecific pattern. You see the injury after the laser, and then before, and then after, you're starting to see better recalibration of the dermis and the environment there. So you see these better round-edged dermal papillae. And before, you could see this coarse collagen with, sort of disarray of the collagen fibers. But here, after a CO2 laser, you're getting reestablishment of these organized, reticulated collagen fibers arranged in a more symmetrical and structured way. And so over time, we're really changing the architecture of the dermis with our lasers. And you could see it's really improved. And so, and to tell you the truth, in clinic, we also use these imaging devices because patients don't always see the apparent change. Like, you can show them the before and after of a static 2D image, and they're like, oh, But when you actually show them these tools, they really become invested in them. So you can see how well this went from an atrophic scar to a recapitulation of a normal-looking skin, epidermis and dermis. So, Dr. Tierney touched on this as well. The layering of AI, not just artificial intelligence, but really augmented intelligence is where we're going with all this, right? So using these imaging tools, collecting all these images, and with all those images, you get such a robust amount of data, and you can then section these images and really tease out what we're looking at, and then using AI, we can really enhance our intelligence and enhance our diagnostic acumen. And we could really perform better as clinicians. So it's really not that machine learning and robots are replacing us, they're really just augmenting us and layering upon the imaging tools that we have. So the challenges are, we have to direct where we're going with this technology, obviously, and there's a whole host of applications for OCT, RCM, and beyond. And we are seeing in dermatology a rapid rise in melanoma diagnosis. And I think it's because we have all these tools and we can screen more people now. We're actually diagnosing this even earlier, and the prevalence or the incidence is going up. So we really have to be careful about detection pressure in low risk populations, who we're screening, what lesions we're screening. We have to be, sort of discriminate and discreet about screening, what we think is true. So always starting with the clinical base of the pyramid. But the future looks bright, no pun intended, and happy to take any questions, or of course, Dr. Tierney, any questions for him as well. And thank you to the whole team at Sloan Kettering for all the work that they do. Thanks.